And good morning. It is July 11th, 2023. We are broadcasting our spine surgeries today live from the Duke Spine Institute here in Melbourne, Florida. And our first patient travels to us from Idaho. He's here with his lovely wife, and he's here because he has two herniated discs in his neck, in the cervical spine, C3-4, C6-7. He has radiculopathy. He's also had ulnar neuropathy, a pinched nerve in the elbow, which was treated by a different doctor. He's noticed some wasting of his muscles and loss of strength in his right arm. We always approach the spine from the opposite side of the arm that's the most affected. He definitely has a herniation. You could see it on the MRI down there at the bottom of your screen at C6-7. He's completely asleep, intubated, and we're going to go in and access the C6-7 disc first through the front. All right, the name of the surgery is Duke Laser Disc Repair. Shot. Looks good. 2, 3, 4, 5, 6, 7. Give me a little shoulder pull, just a little shot. Beautiful. All right, so that looks good. I need an AP view. Let's go AP, quick. Now the fluoro is set up on the opposite side of me. That's so that we can do the AP and lateral view alternations. That's perfect. Go back to a lateral view. You can see on the AP view that we're in the middle of the cervical spine with the needle. That's really good. Now I'm just going to enter the spine through the front. I need a little bit of shoulder pull. 2, 3, 4, 5, 6, 7. Everyone agree 6, 7 shot? All right. Well, let's do this. Shot. We're now in the front of the spine. I'm a little bit lower than I want to be. Shot. That's pretty good. Give me an AP. 2, 3, 4, 5, 6, 7. Quick AP. It's too far to the right, so I'm going to come back, move a little bit to the middle. There we go. Shot. All right, that's perfect. Lateral. Sorry, things are moving quickly, but we need to move quick. That looks like I'm a little bit south of where I want to be, and shot. That looks perfect. We're in. Let's get a coker. We are now shot inside the disc. Okay, give me an AP. I could feel the needle go through the front of the disc called the annulus. 2, 3, 4, 5, 6, 7. Perfect. See, we are entering the middle. Show them the middle. That's right. All right, very good. And we're just to the side of the esophagus. You can see the esophageal probe there. All right. At this point, we have put our needle at 6-7, which is the first disc we're going to fix. Now we're going to place our second needle at C3-4. He has two herniated discs. The most symptomatic is the bottom one, but he wanted the C3-4 fixed as well, and I thought it was reasonable. So he's traveled far to get here. We want him to leave and not have to come back and have another procedure done. Shot. All right, so that's too low. Got to give my fingers a break. This procedure is hard on the fingers because the surgeon has to literally move over the trachea and esophagus. So we have to push down on the spine and then move them over to create a small window to enter. All right, so I need to be a little bit further north. He's still relaxed. By the way, in case you're wondering, the anesthesia for the surgery is called general endotracheal. You can see the endotracheal tube on the x-ray. This patient is completely out and is totally asleep. All right, I feel the spine. Let's hope that we're high enough here. And shot. All right, close. Let's go a little bit higher. And shot. Okay, it's pretty good. Give me an AP. Quick. right there. AP. That's good. Back to a lateral. Can see how the esophagus has moved over. Shot. All right, I'm happy with our shot. I'm going to go in here. Shot. Shot. That should be midline. Shot. I'm hitting the top of the top vertebrae, inferior end plate. Shot. Give me an AP. Not bad. Lateral. Now you can be about a centimeter off of the dead center on either side. Shot. There we go. Shot. Huh? Yeah, right? Yeah. He's got a little bit of calcification in the front. AP. Why is the floor wet? Oh. Let's get a little towel right here or something. It looks good. Yeah, looks good. All right. At this point, we've placed our spinal needles percutaneously through the skin. And I'm going to do the next step, which is a discogram. Now, a discogram is a procedure where we inject liquid into the disc in the center. And we're looking for a few things. Number one, we're looking for any type of abnormal disc damage to the disc. Specifically, we're looking for tears in the back of the disc that would cause a herniation. Let's do 3-4 first. Shot. All right, there you go. Look at the tear in the back. Jordan, show us that tear. Henry, you see that? Yeah, there it is, right
Yes,
there.
we do.
See the dark line and that whole herniation there. There it is. So you can see the arrow pointing to the herniation, right?
Yes, we do.
All right, that's 3-4. Let's go down to 6-7. I need an inline traction on the neck. I need a little gentle shoulder pull and wrist strap pull. Everybody, I'm going to give you a count of 3, and then we're going to take an x-ray to make sure that we can visualize the disc. And then I'm going to inject, and we'll do a second x-ray. So everyone get in position. Go ahead, Luis. Both shoulders. Do both shoulders. You just grab it and pull it in. And shot. All right, we need a little more pulley. Shot. All right. I don't know. It's not good enough for me. Let's bring the fluoro south just a smidgen. Maybe that will help. And Luis, you're grabbing and pulling down and in, right? And you got to hold the head north, otherwise the whole body moves south. Yep. Shot. All right, well, that's probably as good as we're going to get. Shot. There it is. Great. You got that, Henry, there? You guys can relax.
Yes, we do.
Let's do an AP. So Henry, Jordan, on that one, lateral, show us the tear and the herniation. We're going to stay with the lateral image there, Henry. Can you see it, the arrow?
Yes.
There's the tear. And then show us the herniations. Yeah, you can see a double, like a breast on the side. I hate to say it, but that's what it looks like. It looks like two. If I do that, people are going to get upset. But it looks like a double shadow. I don't know how you describe it. AP. So on the AP, you can actually see the tears. Show us the tears at C3-4. He's got bilateral disc tears, annular tears on both sides. And the dye is leaking out on both sides. But look at the left side, other side. There you go. Look at that herniation there. So we're going to be removing that herniation there. Yeah, very good. Okay. You can actually see, stay there for a minute. Show the dye on the nerve root on the right side. Go down to the right side at 6-7. There. You see that nerve root right there, guys and gals? That dark thing?
Yes, we do.
That is the nerve root. That is the nerve root. C7 nerve root on the right. That's the one that's being affected by this condition. So we're going to go in there and decompress it. All right. So, we're going to start at 6-7, the bottom disc. I told him when he leaves here, he's going to have 2 small 4mm punctures on his neck. And it's going to look like he came to Florida and got attacked by a vampire. I'm going to do a little numbing medicine in the skin so we can do an incision. The incision for the surgery, since it's arthroscopic surgery, it's called the Duke laser disc repair, for those of you who want to know the name of the procedure. We've been doing it 16 years. It's been peer-reviewed and published in the medical literature multiple times. It's FDA approved. Everything we use is FDA approved. Incision. It's literally a 4mm incision. You all see that? Okay. And I need x-ray guidance, guys. I'll get it. But I need you to give me a little shoulder pull, inline traction. We're going to take the needle out and leave the guide wire. See, that's very good. That's a nice shot. And shot. All right, you can see the guide wire is still there. The needle is making its way out. I'm twisting it and pulling it. Shot. All right, perfect. Needle is out. You guys see that? So basically, we introduce the guide wire through the needle. Looks good. I don't see any evidence of hematoma. I'm always checking. The neck is supple. Vitals are stable. Now I'm going in with the dilator. And I need to watch my guide wire. I need to see the guide wire. I can still see it well. Give me a little better shoulder, guys. Show it to me. Shot. There we go. You can see the tip of the guide wire. Jordan, show us. You don't want the tip going too far back. Shot. Sometimes you can trap the actual guide wire with the dilator. Shot. And then the two of them move forward together, and you don't want that. All right. Folks, let's show the audience here. I need a little bit of light here. Can you guys see this, Henry?
Yes. Yes, we do.
Look at how tiny. The whole surgery is going to be done through that little cut. Okay? So now we're at the front of the spine. Shot. And let's get an AP. I want to make sure we're in the midline or close to it. You don't have to be dead center for the cervical spine, but you want to be about a centimeter left or right of the midline. We're pretty much dead center, so it's perfect. You want to aim for dead center, but if you're off a little bit, it's okay, because you've got this like a little road that runs in front of the spine. It's called the anterior longitudinal ligament, and it's safe to go in anywhere in the anterior longitudinal ligament. You could even go in a little off to the side in what's called the longus colli muscles. They're safe as long as you don't go too far into them, because you've got your sympathetic trunk in there. So my advice is stay out of the longus colli muscles completely. Then you don't have to worry about your patient getting a Horner syndrome after surgery. Spelled Horner, H-O-R-N-E-R. Horner syndrome is when their sympathetic trunk has been damaged by usually cervical spine surgery is the most common reason, where the surgeon makes the mistake of cutting through the muscles too much and damaging the sympathetic trunk. Then the patient wakes up with an abnormal pupil and abnormal sweat and redness on their face. And that's permanent. It's bad. All right. Now, you can all see that we've placed our dilator, which is about 2.8 millimeters, almost 3 millimeters. And now the whole surgery, Henry, can you see this tube?
Yes, we can.
The whole surgery is going to be done through this tube. This is a surgery that's going to replace ACDF, anterior cervical discectomy and fusion. It's going to replace artificial discs in the neck. And the only reason why your surgeon's not recommending it to you today is because they're making too much money doing the other surgeries. It doesn't pay this surgery does not pay surgeons as much. So there's a lot of surgeons that don't want to do surgeries because they make a lot less money. shot. You know, I didn't understand that concept until I saw it firsthand. And it first became apparent to me when artificial discs were FDA approved. And I saw that a lot of doctors were not doing the artificial disc because it paid so little. Shot? All right, we're right on the spine. That was literally the issue. It paid literally 25% to the surgeon of what a fusion paid. So you can make 4 times more doing a fusion. It's still a problem today. That's why a lot of surgeons won't do artificial discs. Me personally, I don't think artificial discs work well. I've seen the complications from them. I'm aware of them. They've been buried by the industry. The companies that make artificial discs have been hiding the complications for years. And the only meeting in the world that exposed the complication of the artificial disc back in the early 2000s, like 2005, 2006, 2007, was a meeting that we had where the chairman of the meeting was adamant about honesty and integrity in research. And he would make sure that the surgeons that knew about complications would talk about them to other surgeons, okay? That was Dr. Cahill out of Tampa. He was a highly respected spine surgeon, orthopedic spine surgeon, and he had a meeting every year where we would all go, hundreds of spine surgeons, and he would allow the truth to be told. Now, you can't go to a meeting and hear the truth anymore because the industry that manufactures artificial discs will not allow talks on the complications. And if they do, they won't allow anything about the complications from the devices, like them falling apart, them causing heterotopic ossification, loosening, adjacent segment disease, fusion, autofusion. So these artificial discs have all kinds of complications, but the manufacturers of the artificial discs will not allow that to be published. They will not allow it to be presented at meetings. They hide it. I know this for a fact. I was there. That meeting got shut down. Dr. Cahill's meeting got shut down. Actually, he got killed in a plane crash. Makes you wonder. Yeah, makes you wonder, doesn't it? What was that movie, The Firm, with Tom Cruise?
Great movie.
Yeah. Anyway, Dr. Cahill. I need my scope on. All right, we're going to get started at 6-7. We're at the back of the disc with this tube. What we're going to find back here is the herniation and the annular tear. And we're going to use the laser to clean it up. Now, we got an issue here with this too bright. Let's get the brightness down. That's perfect. Thank you. All right, so it's a little blurry. I'm going to try to sharpen it up a little bit. There we go. This scope is different than the lumbar scope, for those of you wondering. The lumbar scope is what's called a rod lens scope. It's the best type of scope you can get. The image at the bottom of the tube is projected in a rod lens scope through lenses, little lenses, high quality lenses. But with a fiber optic scope, like the cervical scope I use, the image is projected through fibers and not a lens, unfortunately. So the quality of the image is less. It's degraded because it's broken up into, I think it's 5,000 little areas and then transmitted through this fiber optic thing, this fiber, these little pieces of glass. Anyway, getting back to my conversation about artificial discs and the industry and hiding the truth, it's a shame because now all the neurosurgery meetings and orthopedic surgery meetings are sponsored by the same companies that were hiding the truth about the results of these surgeries, the complications that happen. And they didn't want anyone to hear about it. They wanted surgeons adopting their artificial disc, using the artificial disc. They didn't want to give them a reason not to use it. And there's still some good surgeons out there that are willing to tell the truth. They're not basically on the take from the implant companies. Not many of them, but there's a few, like myself. We don't take any money from these companies, and we want people to know the truth. I think the truth is a very powerful tool. And the truth, if you are not afraid of the truth in life, you can actually take the truth and you can find ways to fix problems. Okay, most people hide from the truth. They want to deny the truth. They're afraid of the truth because they don't know how to deal with the truth. I didn't know how to deal with the truth either, but I had to figure out a way to deal with it. My dad would kick my ass if I lied or if I was dishonest, so I had to learn to be truthful and to accept the truth and to deal with it. And I think it comes from parenting, good parenting. Good parents hold their children accountable to the truth. And by doing so, it forces the child to reckon with the truth and to find solutions, truthful solutions, honest solutions to problems. I think we're still way overexposed. I mean, there's so much light intensity here, I can barely see anything. That's better. Why do we get so high on the light intensity? Is it the bulb? That's a little bit too dark. Give me one click up. I don't know. Maybe it's just hazy. I guess that's okay, huh?
One more.
No, it's too bright.
No, I'm saying no. Here, the power of the light. Hold down. Let's see.
Sorry, folks. We're just adjusting our light source.
Go down. Let me see.
All right. Any questions from our audience, Henry?
Yes, we have a question from Canes25 on YouTube.
Good morning. Wow, I feel special. I mean, there are people that actually follow us regularly. It's pretty cool. Good morning, Canes25.
They said, "Good morning, good doctor. I have a question. Can a CSF leak be missed on an MRI, and what is the gold standard for finding a leak that's been suffering from symptoms for 2 years? And I believe they are missing it. I have severe bone spurs at C3-4 on the right side, sitting on the dura. I suspect it may have been punctured. It may have a punctured dura, possibly, and a perennial cyst at C5 on the right side. No one has seen anything on the MRI, but all symptoms are there, and they're missing it. That I am certain. Please, if you can enlighten me on this subject, I take your opinions over any other."
Well, thank you. So great question. The question is, how do you best diagnose a cerebral spinal fluid leak? And is the MRI the best way to do it? The answer is no. The MRI is a terrible way to find a spinal fluid leak, okay? It all depends on the cause of the spinal fluid leak. Now, what you're saying is, from what I can understand, is a spontaneous spinal fluid leak, meaning most spinal fluid leaks happen after spine surgery or brain surgery, and they're caused by the surgeon doing surgery. If I understand you correctly, you've not had surgery, and this is a spontaneous CSF leak or fistula. And those are not common. They're very rare, but they do occur. So you could have one. It's unlikely, though. If you haven't had surgery, it's highly unlikely you have a spinal fluid leak, but it's not zero. So the symptoms of a spinal fluid leak, that spontaneous spinal fluid leak, is headaches, positional headaches. You get up, and you sit up, stand up, your headaches get worse. You lay down, the headaches get better. That's the most important symptom complex, is headaches, maybe some photophobia, like light bothers your eyes when you're up, gets better when you lay down, okay? And what you need to research online is spontaneous CSF leak, okay? Or intracranial hypotension, spelled INTRACRANIAL. It means within the skull, intracranial hypotension. Hypotension means low pressure, all right? So spontaneous intracranial hypotension, that's what you want to research to get answers. Look at that herniation right there, pretty cool. I'm going to try to grab that one out. probably about 2.5 millimeters. It's not huge. But there's a little herniation there. All right? So what's the best test? Well, you know, tests have evolved over time, but when I was resident in neurosurgery dealing with spontaneous intracranial hypotension, we would look for a CSF fistula where the spinal fluid would be going into a vein or somewhere around the spine in the epidural space, okay? And one way to do that is called a nuclear medicine study, a nuke med study. And it's where the radiologist would inject some radioisotope into your spinal fluid through a lumbar puncture. And then they would scan you hours later and look for that isotope being found in other parts of your body. And that would tell them that it left where they put it, you know, in your spine, in your thecal sac, in your CSF. So what you need to do is go see a neurologist, and ask them to evaluate you for spontaneous intracranial hypotension. A neurologist, okay? That's what you need to do. Great question. Hopefully that helps you. But MRI is not the right test. You won't see it with an MRI.
We have another question.
You can see a brain MRI evidence of a spontaneous intracranial hypotension, right? On a brain MRI. You can see the bottom of the brain and the dura kind of enhancing. It's complicated, but it's not the best test. And it's definitely not a spine MRI. Okay? Yeah, I'll take the next question.
This next question comes from Im Yisrael Chai, which I believe means Israel lives in English.
Nice.
And they're on YouTube, and they ask, hello, after a long fusion T4 through L3 scoliosis, I have a lower back pain but no massive disc pathology. Is it still possible that that my back pain, that I can get help for my back pain to have this procedure?
Yes. Yes. Your pain is coming from a disc. You may not think you have major disc pathology, but you do. The only way to know is to show me your MRI and to do a telemedicine. So that's what I would recommend. We do a free MRI review at mri.dukespine.com. Henry, who actually visits Israel quite often, and his family is there, Henry will share you the link. How's that? Good?
Perfect. Got it in.
All right. But your discs are the reason you're having back pain. So most doctors don't know that, and they'll tell you it's not your disc, but it is. We've discovered that it is the disc at Duke Spine. 90% of the time it's your disc. And the doctors miss it all the time. All the time. They say you have a normal MRI when you don't. But those disc bulges are the cause of your symptoms. As long as you have an annular tear, you have a reason to have back pain. My job is to look and see if that matches up, your back pain matches up with the herniations or bulges. Yeah, that's what we fix all the time. People just like you who are told there's nothing surgical there when in reality there is. So I hope we can help you. All right, who's next?
The next question, this is from a little bit earlier. This is from Canes25 on YouTube. And they asked, did Dr. Cahill get John McAfee?
Did Dr. Cahill
get John McAfee? Like, I confused who John McAfee was.
I don't know.
Yeah. But I think it's just revolving around like a conspiracy theory that Cahill was not, the plane crash wasn't an accident, I would say.
I honestly think it was not an accident.
You okay? I need another laser power. Please.
All right, so at this point, we're going to change our laser fiber. Actually, you could probably use that.
Yeah. Let me see.
Just cut it.
The vice grip. And another laser power. Yes, please. Thank you.
So we have a little more herniation to get over there. And yeah, we're changing our irrigation. You can see what happens when the irrigation stops. We get some bleeding. But what we're dealing with back here is, you can see what's called the posterior longitudinal ligament. That's that blue stuff. And what's happened is the herniation is stuck to it. The herniated disc is stuck to it. What's wrong with that fiber? Let me just have it.
Oh, let me strip it a little bit.
No, no, don't worry about it. Light on.
Light on, please. Thank you.
Laser's off, right?
Light on, please. Let me see.
It's fine.
Ready? Ready.
Yep. Laser on. We have irrigation, good. You can see there's a lot of herniation down here. Here's another piece. I need to grab, oh, here it comes. Please don't do that. I may have to grab it. It's not coming out. We're missing a little bit of light in the OR, guys.
Can you put X-ray? Thank you.
All right, there it is. A little piece of herniation, about 2 millimeters, 2.5 millimeters maybe. And between these discs, you can strip it, all right? You understand what I'm,
Yes, sir. Yes,
when
sir.
I move to the C3-4?
Yes, sir. Yes, sir.
All right, so we're at the back of this disc here. And we're seeing a lot of pieces of herniation.
We have a question.
Yeah.
This comes from Billy Jones on Facebook.
All right, yeah, we're going to need to strip it. Yes, I'll take Betty Jones's question.
Billy asked, "Hey Doc, what is your opinion on the opioids and doctors not prescribing them after surgeries even?"
Yeah, it's crazy, huh? Well, first of all, we do Duke laser disc repair without opioids. So, but this is minimally invasive surgery. But we're talking about open back surgery and open neck surgery. Why don't you strip it? And the doctor should be doing opioids for those types of procedures.
Lights on, please.
Open spine surgery like microdiscectomy, laminectomy, fusion, artificial disc, they're all very painful surgeries. And the problem is you cannot do those surgeries without prescribing patients opioids. I think it's basically malpractice for a surgeon to do open spine surgery like microdiscectomy, laminectomy, fusions without giving opioids to patients, okay? That's just a necessary treatment. Now, it's funny you talk about it because there's a reason why opioids are becoming very hard to get, right? It's because it all comes back to money. And if you understand the money, you follow the money, you'll understand why there's a war on opioids. The war on opioids is because the insurance companies are always looking for ways to save money and not pay for your medical care. Now, they would spend over $3 billion a year on opioid painkillers out of their pockets. $3 billion. So somebody at the insurance companies got smart and said, you know what? If we can stop paying for opioids, we'll save $3 billion. It'll go to our bottom line. We'll be profitable by $3 billion more. And they said, well, how can we do that? People need the opioids. Well, we'll have a war on opioids. We'll go to the New York Times, we'll go to the Wall Street Journal, and we'll make some stories. We'll get some journalists to write stories about how opioids are killing people. They are killing people, by the way, so it's true. But they've been killing people for the last 40 years. So why now? Why are they going against the opioids now? And the answer is this. If they can get rid of paying for opioids, and they can substitute, instead of opioids, marijuana, then they don't have to pay for the marijuana for people to use for pain. They just have to pay for opioids, because opioids are prescription. Marijuana is not prescription, and it's federally illegal. So basically, they've converted our country from being on opioids to being on marijuana for pain, and they don't pay for the marijuana, but they did pay for the opioids. So it's not really for your guys' best interest that this war on opioids is happening. It's really for the insurance companies, profits. That's what's happening. Now, do I think opioids are abused? Absolutely. Should we be treating chronic pain with opioids? Absolutely not. But should patients be able to get opioids after surgery? 100%. You need it. It's cruel and inhumane to not give a patient painkillers that are appropriate for their pain. And after all, with surgery, your pain is an acute pain, meaning that it's not going to last. It's not like you're going to be taking these drugs forever, right? There's a finite amount of time you're going to be on them. So let's be reasonable. People having surgery need opioids, period. But so the surgeons, they just want to avoid, having to write you for the opioids. So what they'll do is they'll tell you, yeah, I'm going to do surgery, and yes, you'll need painkillers, but I won't write you for them. In other words, they're saying, go find it from someone else. Okay? That's pretty irresponsible of the surgeons. I think it's wrong for them to do that. If you're going to do surgery on a patient and you need opioids, you need to make sure they get the opioids. Not just, say, hey, good luck, get out there, and if you're going to suffer, you're going to suffer. They're just not dealing with the problem. So what's going to happen is you're going to have this painful surgery. You're going to call the surgeon, and they're going to tell you in the middle of the night, go to the emergency room. That's bullshit, because they shouldn't be sending you to the emergency room for a problem they know is going to happen, that they themselves should be managing. Now, if you're going to the emergency room in the middle of the night looking for opioids, what do you think the emergency room doctors are going to say about you? Okay? The surgeon doesn't care as long as they get their money for doing the surgery. They don't get money for giving you opioids. Does that make sense? I think the tip is missing, isn't it? The tip is gone. You got to restrip it. Give me a second here. We're just
Are you ready? Stand by.
fiddling with the laser.
Stand by.
Light on, please.
Light on, please. Thank you.
It's not where we need it. You have a blue, yeah, can you adjust that so that Luis can see what he's doing? That's good. All right, great questions. So the opioid crisis is real, but it's contrived. It's real that it's been a crisis for many years, like 30, 40 years since the 80s, but it's not a real crisis like it's just started. It's always been there. The reason why it's becoming a national attention and doctors and pharmacies are being criminalized for prescribing them is because the insurance companies don't want to pay. They want to basically take $3 billion profit more home. Okay? That's really what's happening. And you guys are all being the victims. Now, my surgeries don't require opioids. During the surgery, we give a little bit, but afterwards, you don't need opioids. When you go home from our surgeries, you take a Tylenol, that's it. So I agree with the whole concept of less invasive surgery and not needing opioids afterwards, but I disagree with doctors doing surgery that needs opioids afterwards, and they're not providing it to their patients, and they're letting them suffer. So I think it's a complicated question and answer thing, but I think you'll understand my point. I'm a bit surprised at just how much hernia. Look at all these pieces of herniation. It's like never ending here. I've taken out at least 15 to this point. There's another big one. It won't even come out of the tube. It's so big. So this is how the surgery is done. It's just you remove one little piece of herniation at a time. It can be a bit painstaking in some patients, but very rewarding, because this patient was recommended for a fusion by the other doctor that he saw, and he didn't want a fusion. And he's from Idaho, where that's all they do is fusion. So he said, you know what? I'm leaving Idaho, I'm going to go to Florida, and I'm going to have the endoscopic surgery done. And that's why he came here. These are all bone spurs right here. I've been removing them without talking about them. But Henry, let's go ahead and show our audience, why do herniated discs, this is scar tissue, just so you know. Why do herniated discs cause so much pain? This is all scar tissue right here. You guys see it stretching there? This scar tissue is here from inflammation. The herniation causes inflammation to happen. So that's why we want to get rid of the herniation. It's not just about putting pressure on the nerve, it's also about causing inflammation. And if you can get rid of the herniation, you get rid of the inflammation. That's our goal. All right, go ahead and show our audience our video on how to herniated disc actually cause pain.
Traumatic injury on the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissue develops within the annular tear, causing neck pain. The inflamed annular tear generates pain signals. Additional injuries can cause worsening symptoms. Inflammation from the annular tear can spread to the nearby nerve roots, causing arm pain. Pain signals travel up the nerves to the brain, causing localized neck pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of neck pain. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.dukespine.com.
All right, welcome back. You can see from our video how a herniated disc causes so much symptoms in people's necks, right? Everyone thinks that it's pressure, but it's not. It's actually coming from inflammation. And the inflammation is created from the herniation, the herniated nucleus pulposus that's located in the back of your disc. The nucleus pulposus herniates in the back of the disc, and it gets stuck in the annular tear. And the annular tear is vascularized. It has blood vessels. So the annular tear is going to get inflamed and respond to that piece of herniation there that shouldn't be there, right? And so that's going to create a lot of symptoms for the patient. Neck pain, headaches, shoulder pain, all those symptoms are coming from inflammation. Just about done. Yeah, thanks. All right, just going to look back the other way just one more time. And it seems like a never-ending procession of herniation. All right, let's take the questions.
This next one comes from Bally on Facebook.
Hello, Valley.
They ask, if a person has L5 to S1 severe dehydration and prostration and annular tear also, and has hip issues on the same side with wear and tear and some degeneration and arthritis, but not causing much issues at that moment, however, can a back surgery be done first, then in the future, if the hips need to be resolved, then can it be done? Can it be done, or should a hip issue be resolved first before even having back surgery?
Yeah, great question. My advice is to do our free MRI review. And what we'll do is we'll tell you what's coming from your hip versus your back. And then you can decide. But let's assume you're having equally bad pain from your hip and your back. I would definitely do your back first with Duke Spine Institute. I would not go anywhere else. And I would have this minimally invasive surgery done, the endoscopic DLDR. And here's why. In about 3 months, we're going to be doing a minimally invasive hip surgery where you don't have to have a hip replacement anymore. You can actually have a 15-minute procedure that will get rid of your hip pain permanently for the rest of your life here at Duke Spine. It's called the Duke Plasma Rhizotomy. It's only available here. And it's going to literally put the hip replacement doctors out of business. But it's not available today. It's going to be available in about 3 months. So, get your back fixed with the Duke laser disc repair, and then come and get your hip fixed with the Duke Plasma Rhizotomy. There's no downtime, and it's outpatient. My hands are freezing. I think that's about it right there. I've gotten all the herniation I can get safely out on both sides at 6-7. You can see a lot of calcium, the gold stuff. We've gotten rid of some bone spurs too, some of them that were in the way. Take one more peek and we're done. Every time I peek, there's another little piece there. It's popping out from around the corner. How many pieces you guys count? I'm up at around 30 now. You can see the foramen is open. There's no more herniation here. Just some scar tissue of the ligament. And I feel pretty good. Oh wait, there it is. Look at that. Haha, it's a good thing I went back. All right, so hopefully that's the last one, but you see how it was hidden. Some of them can look like scar tissue, but that's a piece of herniation. And it is scarred. No, I have to get it out.
Oh,
Yeah. Whew, my hand is cold. Yeah, that thing was just sitting in its crypt like a vampire, just laying there waiting. It rose up. Huh? Tales of the Crypt. Wow, that was cool. So it was right there. See that? Now it's gone. Let's see, maybe there's something else. There's a little bone spur right there. All right, what other questions do we have from our audience?
No current questions, but we do have a comment from Billy when asking about the opioids and doctors not prescribing them after surgeries. He said, "I had an ACDF back in April, and we used to we had to ask 3 pharmacies till we found one that had the prescriptions in stock." Thank you for your answer, Doc.
Yeah, no problem. Yeah, the pharmacies were attacked by the insurance companies. So just so you understand, the insurance companies use the Department of Justice. It's called the DOJ. They use the DOJ to do their dirty work, okay? And that's a real thing. And so what's happened is the DOJ's gone after the pharmacies for filling prescriptions, okay? So they're now totally regulated on how many opioids they can get at the pharmacy, okay? Because of the stupid insurance companies just trying to save more money for themselves to be profitable. And people are suffering. So I don't know if you heard this, but the DOJ went after the pharmacies like CVS, Walgreens. They had to pay like $5 billion in fines for selling the opioids to people like you going to the pharmacy. Now, I don't think it's their fault, personally. I think that the insurance companies just want to punish everybody that's involved so that they feel the sting of the scorpion, so that they leave it alone. They get away. They stop prescribing opioids. They stop stocking opioids. They stop prescribing opioids. They stop distributing opioids. Meanwhile, people like you suffer. I think it's wrong. But it's all being driven by the health insurance company to save money. Hell, not to save money, to be more profitable. Let's face it. They're already profitable. They want more profit. And they're willing to make you people suffer for it. I think it's totally wrong. Why is it CVS's fault for filling a prescription that a doctor ordered of oxycodone, OxyContin, right? Why? It's not. So why did they get fined billions of dollars, $5 billion, and they have to pay it? And that's a lot of money. By the way, where is that money going? Now that the government has fined them $5 billion and they paid it, why don't we see any of that money? Why don't the public, why don't the voters, the American taxpayers, why don't we see that money? Why is it not coming back to us to help us? Have you guys ever seen any of the billions of dollars the American government gets from hospitals, doctors, for these alleged crimes? I haven't. I'm a doctor. I run a medical clinic. I've never seen a dime. They just keep taking more and more money from us. Anyway, I'm just as frustrated as you are. I think it's wrong. I think it's all a scam. It's a scam that's induced and created by the insurance companies to save money and not pay for opioids, okay? And they want all you guys doing marijuana, which they don't have to pay for. That's what they want. So they've legalized marijuana, and they've illegalized and criminalized doctors and pharmacies and hospitals that give out any kind of pain pills, okay? They're taking over medicine, folks. You guys need to be aware of the truth. I'm sorry I don't have a better answer for you, but the solution is to regulate the insurance companies and don't let them steal your health care. I already numbed it, but I'll do it again. We're going to move up to C3-4. I'm going to numb the skin one more time. Numbing is good because, you see, even though the patient's completely asleep, when there's pain, even if you're asleep, you still have what's called a subconscious response. That's where your brainstem, hold on, your brainstem responds to the pain, okay? And your brainstem happens to control your heart rate, your blood pressure, all those good things. And when your brainstem feels the pain, even though it's subconscious, your cortical part of your brain doesn't feel it. Your brainstem feels it. Let's go, all right, good. Then you're going to have a response with your heart rate going up and your blood pressure going up, okay? So by numbing the skin, even when the patient's asleep, it helps reduce that response, that reflex response.
And you block the local sensory response afferent pathways. By blocking it, you stop the inflammatory cytokines, substance P. You stop all that. That's preemptive analgesia.
Interesting. I didn't know about that.
Yeah.
Learn something new every day. Dr. Berndes says that it also helps with inflammation. All right, let's get an AP. Any questions? So we finished the 6-7 disc. We're moving up to the 3-4 disc. The 6-7 was a pain to fix. There were literally over 30 pieces of herniation there. 3-4 hopefully will be a different story. All right, lateral. Looks good. We're a little bit off to the right side, so I'm going to aim a little bit off to his left side. We should be fine. Lateral view. All right. And I'm going to take out my guide wire. Shot. Shot. We've already done our discogram. Shot. You can see the bones separating as I go in. Shot. All right, we are at the back of the disc, sitting in the herniation. Great questions from the audience, by the way. We've lost probably 5 drops of blood the whole surgery. Here. Sean? Got to get my tube down on the spine. So the tube is sliding over the dilator. We call this a tubular retractor. Very nice. Now I've got to advance this tube through the disc, through the annulus, through the nucleus. People ask me, well, doesn't that make a hole in the disc? The answer is no. We're spreading the fibers of your disc in the front, and the annulus is fibrous, so we're not making a hole, we're just separating the fibers. And then when we're done, we're going to take everything out, and of course the fibers will go back to where they're supposed to be. The nucleus in the middle is semi-liquid solid, and it's like jumping into a pool with water. You can't cut the water. All you do is separate it. All right, you see how the dilator went forward? So we have to be very careful and not let the dilator go forward. And it's kind of cold welded there. Cold welded means, there we go, that there's something stuck between the dilator and the tube, like a piece of disc material. And shot. And that's causing the two to move together as one. Just like again there. You guys see that? So it's very important that you're constantly paying attention. Shot? Because if you don't, you could really hurt the patient. This is not, I make it look easy, but it's not an easy surgery. Shot? So I'm moving my tube forward millimeter at a time because I'm just trying to be very careful. All right, now we're at the back of the disc with the tube, and I think that's good. I'm happy with that positioning. The end of the tube is at the back of the disc. Show them, Jordan. And it's docked right where the annular tear is, and we should be able to get rid of the herniations. Okay, any questions?
Yes, we have a comments and a couple questions. These first comments come from Canes25, talking from going back on his on the C3-C4 and just the doctor's not seeing anything on the MRI. He has said, yes, sir, I've had 4 spine surgeries, dozens of epidurals, sir. They've been in and out of my spine for over the last 20 years. Thank you kindly for your info on this. You're always on point.
Yeah, if you've had spine surgery and you're having headaches that are positional, then it's a very, very good chance you have a spinal fluid leak. And most spine surgeons are capable of figuring that out, but basically you need to talk to, the surgeon needs to talk to a radiologist and ask them what tests they have available. But like I said, the nuclear med study is the standard old test. I don't know if they have a newer test. The reality is I don't get any spinal fluid leaks, so I don't need to worry about it. I haven't ordered a test in 20 years, but I know other surgeons are, well, they do get spinal fluid leaks, and so it's something that the system needs to be able to address and figure out, okay? I'm just not an expert on spinal fluid leaks anymore because I don't get them and I don't have to deal with them, thank God. I'm sorry you're dealing with it if that is what you're dealing with, okay? So it sounds like if your headache started after your surgeries, then yes, you have a CSF leak until proven otherwise, okay? So we call it a presumptive diagnosis of what's called iatrogenic, meaning the surgeon did it, CSF leak. So I don't know your situation, but that certainly is possible and likely, especially if the timing is there, okay? And especially if your surgeon tells you, there's just too much shit here. If your surgeon tells you you had a spinal fluid leak during surgery, which a lot of surgeons don't tell their patients. They lie to the patients. I always tell my patients, if I have one, I did in the past. I haven't had one obviously in many years, but if I ever had a spinal fluid leak, I told the patient, we got a spinal fluid leak, and I tell them why. And it's never because I was incompetent. It's always because the dura is thin or it was adherent to the nerves and the disc, and or that a lot of times, most of the time, 90% of the time for mine, it's because the surgeon before me, and I'm usually doing, another surgery, revision surgery on somebody else's work. And that other surgeon got the spinal fluid leak, never told the patient, so they don't know they have it. They don't have any more symptoms because it stopped leaking. They come to me, I do their surgery, and I find the spinal fluid when I'm in there. That's typically how I find these things. And when I find a spinal fluid leak, I tell the patient, but I also fix it. So I'll do a fat graft, muscle graft if I need to. And I will try to sew it up if I can. Some leaks you can't sew. You cannot see them and you cannot sew them. Whether it's a complex laceration of the dura, you can't sew, or it's in the front of the spine where you can't see it to sew it. It's possible. All those are possible. Okay? But there are measures we have as surgeons, and they should employ as surgeons to treat the spinal fluid leak. And one of them is what's called fat muscle graft. Another is something called tissue, which is like a gooey stuff you put down to seal up the hole. Another is gel foam, a Duraseal. So there's a variety of products out there. They cost a lot of money. They're expensive. We always have them at Duke Spine in case we do have a spinal fluid leak. We pay for them. We have them. Cost money. But you know what? It's the right thing to do for the patient. A lot of places cut corners. They don't have those products because they're so expensive. So this is a huge herniation right here. I'm like literally cutting through solid scar tissue from this herniation. Solid. You guys see it all right there? Just solid.
Yes, we do.
Incredible. This is the 3-4. 3-4 disc.
We have a couple more questions.
Yeah, I'll take the question.
This next one comes from Bally, once more on Facebook.
Mm-hmm.
They ask, if a person needs surgery on the neck and also in the lower back, would you perform both surgeries at the same time on the same day, or would they be done on different days?
Yeah, great question. Thank you for asking. We would never perform the lower back and the neck on the same day because it's dangerous for the patient to do that. It's not safe. God forbid there's some type of a blood clot or something in the first area that I operate. We wouldn't know about it until too late when they wake up from the second surgery. So, I think normally under normal circumstances it would probably be okay, but I would never recommend that. I wouldn't do it because I just think there's a safety concern. I don't know any surgeons that would. Typically we're taught not to do that, so I'm pretty aggressive in my approach. I'm pretty reasonable, conscientious, thoughtful. And if I won't do it, I don't know any surgeon that would do it that's a good surgeon. I mean, from a technical standpoint, from an anesthesia standpoint, you can't do better than our anesthesia. You can't do better than our surgery. And if we're not willing to do it, there's a good reason why you shouldn't do it. So what typically happens, we get a lot of patients that come to Duke Spine. They do have neck and back problems. They get one surgery done on Tuesday and they get the other surgery done on Thursday. So they don't have to go, come back again. They just do it all in one visit. So we can definitely accommodate people to do it all in one visit. As a matter of fact, we're doing that today. One of our patients is from, where is he from? I can't say. Let me think for a moment. This one is Iowa, right? Idaho, sorry. The Texas one is not. There's another one who is having 5 levels done. And then we're going to, our next case. So it is the next one. So it is a Texas? All right. We got 2 Texans then. So we do have a patient, I think it's the next case, Dr. Berndes says, and that patient is having 2 separate surgeries done. We're going to do the Duke laser disc repair for the discs in the back today, and then we're going to do the actually Duke plasma rhizotomy. He's from California. So the next case is from California, and that's going to be a staged surgery. We call it staged. Stage means we do one part today and we do one part, you know, another time. In this case, it'll be on Thursday. So great question. So today we have a Texan, a Californian. We have a patient all the way from the Cook Islands over by Hawaii. I mean, 6 hours from Hawaii, so it's very far. What's south of Hawaii? Is that where Australia is? Off the coast of New Zealand. And then we have Texas, Austin, Texas, I believe. So we have, everybody today is from different parts of the world, the country. No Floridians, no locals. We call Floridians locals, right? Luis? Luis is speechless. Oh, look at that. Little herniation. So you guys see this disc is very different. I think, I'm almost done, 1 minute. This disc, in my opinion, is older injury than the last one, perhaps. All right. Is the irrigation almost out? Because it's getting sluggish. No, we don't need a switch. I think we're done. Yep, we're done. I didn't see any more herniation. We got all that scar tissue out of there. So I'm happy. Happy, happy. There's an old saying, the enemy of good is what? Huh? No, shut. The enemy of good is evil. I love it. The enemy of good is better. That's right. Don't gild the lily. Do what you need to do to help the patient get out of their problem, but don't go too far. And too many doctors go too far. They do too much. They try to get perfection, and they end up hurting the patient, causing a complication. So at Duke Spine, we don't do that. We believe in doing only what's necessary to eliminate the symptoms. After all, that's why patients come. They don't come and say, hey, I've got a herniation on my MRI, and I want you to get rid of it. Well, what symptoms do you have? Oh, I don't have any symptoms. Then why are you having surgery? I just want to get rid of my herniation. So you're telling me you have no neck pain, no headaches, no arm symptoms, nothing, and you just want to get rid of your herniation? That's right. Nope. See you later. We're not operating. There's no point, even in a surgery like this where it's very safe, to do surgery if the patient has 0 symptoms.
There's no cosmetic spine surgery.
We don't, yeah, you're right. I love that. There's no cosmetic spine surgery.
Not allowed here.
That's brilliant. I love it.
That spondylite looking kind of rough on the x-ray, but we're not going to.
Dr. Berndes hits a home run. I love that. That's a great slogan. There's no cosmetic spine surgery. Why didn't I think about that? Thank you. There's an old saying, I get by with a little help from my friends. All right, so I'm going to use that going forward. I'm going to adopt that saying.
It's not better than the future spine surgery today.
All right, I like that too. Refuse to be fused. All right. Well, unfortunately, we had an attack during surgery by a vampire. You guys see the sequela?
Yes,
Now,
we
this
did.
vampire definitely did not wear braces. Okay, you can see how spread apart the teeth are. All right, looks good. We're going to put a bandage on there, and we're done. So go ahead and type up your questions for me. I will come and answer them face to face. But this guy's surgery went perfect. Didn't have any complications. We lost 5 drops of blood, which is like nothing. He's not going to need any painkillers when he leaves. He's going to take a Tylenol, that's all. We don't use narcotics for these surgeries, and they're all outpatient, so there's no hospital. You're watching the most state-of-the-art advanced spine surgery in the world, the Duke Laser Disc Repair. All right, thank you, Henry, and I'll come answer questions, so type them up for me. My hand is still defrosting. No, that's good. It's good. Cold irrigation. Good morning, I'm Dr. Dumajian. It's December 9th, 2022, and I have with me one of my patients who traveled from out of state, Texas to be exact.
Yes, sir.
And he's suffering with neck pain, and I'll let him tell you a little bit more about his symptoms, but he had herniated discs in his neck along with degenerated disc. We just repaired those yesterday, less than about 12 hours ago.
Yes, sir. Yes, Doc. Yeah.
You're here now on post-op day 1. It was outpatient, no hospitalization. You stayed at the hotel. You're back this morning, and how do you feel?
I feel great.
Good morning, I'm Dr. Dumajian. It's December 9th, 2022, and I have with me one of my patients who traveled from out of state, Texas to be exact.
Yes, sir.
And he's suffering with neck pain, and I'll let him tell you a little bit more about his symptoms, but he had herniated discs in his neck along with degenerated disc. We just repaired those yesterday, less than about 12 hours ago.
Yes, sir. Yes, Doc. Yeah.
You're here now on post-op day 1. It was outpatient, no hospitalization. You stayed at the hotel. You're back this morning, and how do you feel?
I feel great, Doc. You know, I just want to thank you right off the bat for you and your team for basically giving me another lease on life. I mean, the back of my neck, the tops of my shoulders. I had pain all the way down the back of my arm, and my elbow, and then also I had no grip. And today, it's all back. I just, you know, it's just a game changer. His procedures, because I've had fusions in the past, like 15 years ago, and those fusions, you don't want to do those because they just give you adjacent disc disease, and I have that problem right now on my back, and Dr. Dukes is going to fix it next week, so I'm very looking forward to doing that.
We'll be seeing him again next week after his back is fixed, but you broke it up into 2 procedures, and we get people all the time asking us, oh, can I come there and get my neck and my back fixed? Yes, you can. We'll probably do it on separate days. So you got 3 discs repaired yesterday. You can
Yes, sir.
actually see right here in this video footage how small the incision is, tiny. And I was in there endoscopically using a laser to clean out the tear and remove the small herniations. And now here we sent you home an hour after your surgery, and here you are back today. And how much of that pain did we get rid of?
All of it, Doc.
100%.
I mean, 100%. And I mean, doctor did. They did surgery on 3 different levels, and through a really small hole.
4 millimeters.
Yes,
4
Doc.
millimeters. Incredible.
There's no stitches. It's just a Band-Aid.
Yeah.
You know, that's crazy. You know, if you have a fusion for three level fusion, I don't know how long that would be, but it's
it's
terrible.
about that long
Yeah.
for a 3-level fusion. And then of course you'll have swallowing trouble for months,
Not
and
good.
then you'll have pain, and you'll be on narcotics. Are you on any opioids or narcotics?
No, Doc. Last night I went home and to the hotel, and I just took a Tylenol PM, and that's all the medication I've taken since the surgery.
Yeah. So with the Duke Laser Disc Repair, you don't have to worry about getting addicted to painkillers because there are no painkillers. Literally a Tylenol, and that's it, because it's so minimally invasive. Far better than ACDF, far better than any other cervical type of surgery. Well, is there anything else you want to tell your fans out there before we wrap this up?
Yeah, I just want to let my parents know, and my 10 younger brothers and sisters, if they're watching this, if you have back issues, you need to come see Dr. Duke, because he is one of the only people in the world that can do this procedure, and it is a game changer, and it's well worth it. At least give him a review. He'll do a free MRI review for you. It's just do your research. Go to his dukespine.com, look at his website, and just do your research and give give yourself a chance to do the right thing.
Well, thank you. And yes, now I'm the only one, but someday there will be another one
You hope.
who will be doing these
Yeah.
surgeries,
Yeah.
and probably better than me.
Okay, thanks, Doc. Appreciate
Thank
your
you,
help.
sir.
Yeah.
We'll see you soon.
Yeah.
I'm Dr. R. Duke-Majan. I'm here with one of my patients on February 1st, 2023. And you just had surgery on your neck, the Duke laser disc repair done with a 4mm incision to fix 2 herniated discs, her C6-7 and her C7-T1. And you had a long neck. We were able to get down to the C7-T1, and she had a very large herniation there. So your surgery was about 24 hours ago. How do you feel today?
I feel like a different person. I feel I was able to do many things this morning that I haven't been able to do for 4 months, and that is just get out of bed and just take my first steps and have 0 pain. And I haven't had that in 4 months. First step out of my bed was always the beginning of my day, and it was awful. And today I took my first step out of the bed and it was glorious.
Good for you. And before surgery yesterday, you had been suffering for about 6 months with neck pain going into your right arm, correct?
About 4 or 5 months.
How did that affect your quality of life?
Every day is difficult. I mean, I have a 10-year-old and a 5-year-old boy, and just the basic duties of a mother every single day was just unbearable and difficult. So quality of life was not very good. And so it is now.
And so the pain, obviously, because of the pain, activities would set it off, so you were limiting what you were doing. You were limiting what you were able to do as a mother.
Yes, there was things I were not able to do, and be the best mum that I can be was not one of them.
Well, you look very happy right now.
I am.
Why are you so happy?
Because I'm pain-free.
Yeah, and you didn't have to have a fusion or an artificial disc put in your neck, did you?
I did not.
Did anyone offer those surgeries to you?
I did. I was offered those surgeries. I was told that I needed a fusion, the possibility of disc replacement in 1 or 2 years down the road, but it was my decision to go in and have those taken care of if I wanted to. But there was also a possibility that once the doctor got in, that he could not replace those 2 discs, so he'd have to fuse those 2. So that to me was a possible 3 fusion, 3 discs being fused.
Mm-hmm.
And I know the consequences of that, so that's why I came for your opinion, in your professional opinion, what can be done in a less evasive way. Or that was an option for me, and here I am.
And I'm really happy it worked out for you. You can see in the video, we were able to get down to C7-T1, which is really a first endoscopically. And, you know, because you had that nice long neck, we were able to do it. And there was huge pieces of herniation down there. Your other disc was more degenerated, and we were still able to get that fixed as well. So I'm very happy you're doing well. What's life going to be like now that your neck is fixed?
My quality of life is just going to be a lot better than what it was. I'm going to take it easy, and I know that I need to take it easy, and I'm going to be careful, but I'm going to wake up with a smile on my face now instead of tears.
Well, congratulations.
Thank you so much.
Is there anything else you want to tell your fans out there?
Come see Dr. Duke. He'll fix your pain and make you walk out with a smile on your face.
Excellent. All right. Good to see you. Good
Thank
to see
you. Thank you so
You're
much.
welcome. Good morning, I'm Dr. R. Duke-Majan, CEO and founder of the Duke Spine Institute, here with one of my patients who traveled from Mississippi.
Yes, sir. Oxford, Mississippi.
Oxford, Mississippi, which I've never been to Oxford, Mississippi, but I'm sure it's a lovely place.
Very nice.
And why did you come to Duke Spine Institute here in Florida?
I'm having issues with my lower back, shooting a pain all the way down towards my elbow, as well as having a little bit of stumbling while I'm walking within my left leg. And went to other physicians to look at my spine, whatever, and they wanted to do fusion and all kinds of other nonsense that I thought maybe there might be a simpler way, a process of doing things. Did a lot of research and found Dr. Duke here.
And what do we do for you?
You guys did a C3, I think 3, 4, 4, 5, 5, 6 at the Duke laser disc repair surgery.
And before surgery, you had neck pain?
Correct.
For how long?
It's been ongoing probably for about 5 years.
And then pain going from your neck into your right shoulder down your right arm.
Correct, just getting progressively worse, and that's kind of what made me finally to say I got to definitely do something about it.
Here we are less than 24 hours after your surgery, the Duke laser disc repair. You can see the incision right here, it's 4 millimeters. And do you still have that neck pain and pain in your arm?
No sir, zero pain.
Gone.
Gone, completely gone.
Cured.
In shock. Results better than I actually anticipated, which is a good thing, right? That's what I'm here for.
Well, I'm not shocked. It's what we expect to see typically, which is good. The procedure works, and that's why we do it. It works better than anything else. Were you offered any other treatments?
Yeah, they wanted me to go look at a, what do they call a spinal deformity doctor.
Uh-huh.
And they possibly looked at like doing rods and pins and,
Yep.
and all that kind of good, the fusion and everything. So it just kind of,
Why didn't you want to do the fusion option?
long time recovery time and just more of a difficult surgery.
Yeah.
Much more difficult surgery. And me working in a house, I still want to have good quality of life in the future.
Yeah. Well, fusions have complications, a lot of complications. Scar tissue, bleeding, and pain. Are you having any pain right now from the surgery?
No, not at all. Just a little stiffness when I turn left to right, but that's par for the course.
Yeah, the stiffness is going to take some time to work out.
Sure.
You've had bad arthritis in your neck. Your discs were degenerated. You had degenerative disc disease and herniations and bone spur at C3-4, C4-5, C5-6. We went in and fixed all three. You will need therapy to increase the range of motion. It'll take time and you'll get better. Are you happy with your decision to come to Duke Spine Institute?
Very happy. I flew all the way down here from Oxford.
Yeah, very good.
So absolutely made the long trip. I fly back Saturday. And I feel much better flying on the plane than I did earlier. Just thinking, I'm not on any kind of pain medication, none of the muscle relaxant. There's zero pain, so I feel more comfortable hopping on that plane.
And we did it all through a 4 millimeter incision. You could actually see the incision with the little tube going in to your discs. I moved the tube from one disc to the next, and we went back to the back of the disc where the tear was, and I cleaned the tears up with the laser. So that usually does the trick of getting rid of the neck pain when it comes from a herniated disc. And of course, we unpinched the nerve roots that were going down your arm. So that's why your arm is feeling better as well. I don't expect any of that to come back. You should be pain-free the rest of your life. Just don't re-injure the discs.
Absolutely. I'm definitely glad to get my quality of life back. That's the number one thing.
Anything you want to tell your audience?
Anybody that's dealing with the same issues I have, I definitely recommend to come to the Duke Institute of laser surgery. It's a wonderful thing.
All right. Well, congratulations.
Thank you
Safe
so much. I
travels
appreciate
to
it. Thank you
and
so
Dad.
much.
And
We will.
Yeah.
Well, my dad lives in Tampa, so my wife's up there in Oxford taking care of her stuff up there. So
Okay.
worked out good to have my dad here to pick me up and drop me off at the airport tomorrow.
All right. Sounds good. Well, safe travels for you then.
Thank you so much. I sure appreciate it.
My pleasure. All right. Well, I hope you enjoyed that patient's testimonial as much as I enjoyed fixing his pain. We have patients that come to Duke Spine from all over the world. As I said earlier today in the surgery where you were watching me do this gentleman's surgery,
Tad blurry. Just
I
gotta-
apologize.
You gotta recalibrate very quickly if you would like me. It was a moment ago. And no, so close. We're almost there. I apologize.
That's all right. So this is when you hear people say they're experiencing technical difficulties, this is what they're talking about. And that's how we solve it, right? It's all about solving problems. And people's pain in their neck, their back, it's a problem. And that's what Duke Spine is here for. We're here to solve problems. The surgery went well. You guys got to see an interesting cervical surgery. We went on the patient's left side of the neck, right over here. We made one cut there. We made another cut here. So that's why you saw the vampire's teeth were spread apart, because we actually fixed a C3-4, which is pretty much the highest disc in the neck you're going to have a problem with, C3-4. And we fixed number 6-7, which is the lowest disc in the neck. So there were two discs that were fine in between. We didn't touch them. So we had to do one incision here, one incision here. The surgery went perfect. There was a lot of herniations. You could see those pieces coming out at the C6-7. That's the first one we did. and there were probably over 30 little pieces of disc herniation that came out of that tear, out of that herniation. And then the C3-4 disc was primarily a lot of scar tissue. You saw that clump there. I used the laser. We blasted through it. Now, for those of you astute paying attention, you saw we took down some bone spurs as well with the laser. Not every single bone spur was taken down. You don't need every bone spur. Again, we call that gilding the lily. That's bad for the patient. We don't want to overdo things. We want to do just what's necessary to get rid of the patient's symptoms and abnormal physical findings on exam. This patient came to us with pain in the neck that went down the right arm, but mostly weakness in the right arm. He's already had a surgery done on his elbow, and that was done by a different surgeon who thought he had a pinched nerve in the elbow. That was the problem. Certainly was a problem. He had numbness, tingling in these two fingers. That's called ulnar neuropathy. But he also had a pinched nerve in the neck, which we just fixed. All right, let's take questions.
This first question comes from Santosh on Facebook.
Hello, Santosh.
They asked, I couldn't get the endoscope, but despite my best efforts, can you ask Richard Wolf to manufacture these scopes again so that his technique can be popularized?
Santos, I love it. We have the same problem. Richard Wolf is crazy. They're the hardest company in the world to deal with. You're basically going to them saying, I want to give you my money. I want to overpay for a scope. Please give me a scope, and they won't give it to you. Trust me, we've had the same problem. I've had my team looking for these scopes everywhere. We have, in the cervical, we have, I think, 7 of them, and we treat them like, like they're diamonds. We take care of them. We get them serviced all the time. But you're right. Getting Richard Wolf stopped producing them, and there just wasn't a demand for them. And they have, of course, the rod lens scope, which is much bigger and bulkier, which I personally don't like. But I'm sorry you're having trouble getting the scope, but if you find them, make sure you send me one as well for teaching you the technique. That said, Duke Spine Institute will eventually manufacture a scope that will be better than the Richard Wolf scope. And I've already looked into it. The problem is it's $500,000 to manufacture the scope. And that's money I don't have right now, to be honest. It's just cost prohibitive. And it is what it is. But I think someday we'll be able to manufacture a Duke Spine cervical scope. And I intend to do that. And a lumbar scope and a thoracic scope. So unfortunately right now, I'm sorry for your inability to get them, but you're right. We are just as frustrated with Richard Wolf as you are, and they don't answer the calls. Nobody takes any responsibility for helping the customers. We're probably their #1 customer in the United States, and they don't even answer our phone calls. They're crazy. Anyway, I don't know what else to say.
Well, for next question, this comes from, this is a comment. This comes from Canes25 on YouTube once more, going back to talking about their 4 spine surgeries and dozens of epidurals in the past 20 years. They said they also added that they have severe positional dizziness, vision probes, ear fullness, severe tinnitus, constant running nose, clear 2 years. I don't have allergies. And then I'm going to see my PM doctor, pain management doctor, Monday to run tests and find the leak. I don't believe all the tests I've had, they were looking for before it was never brought up, and
Okay.
I figured out on their own. Just
All right. First of all, let me ask you a question. Thank you for sharing your story. It's concerning to me to hear what you're saying. The fact that you have drainage through your nose is very concerning, that you could have potentially a spinal fluid leak into your sinuses. Now, I don't see how spine surgery could do that, but it certainly is possible. That said, here's what you need to know. #1, your pain management doctor will never be able to figure out if you have a spinal fluid leak. You need a neurologist or a neurosurgeon. That's it. Nobody else is capable. #2, Your community neurosurgeon and neurologist will not be able to figure it out, most likely. You need to go to a university hospital. University hospitals are typically where the more complicated problems like yours can be figured out and fixed. University hospital. I don't know where you live, but find the best university hospital in your area. You may have to go to another state, but that's where you're going to find the doctors that can figure it out. And let me ask you a question. If you sit down and lean forward in your chair and tilt your head down like you're looking at the back of your feet, do you start to get drips coming out of your nose? If that's the case, that's a spinal fluid leak, and you're going to need to go and get that addressed immediately, because you could end up with meningitis from that and die quite quickly if you get an infection that goes up. So if you lean over and look down at the back of your feet in a chair, and that causes drip, 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 then that is a spinal fluid leak, and you must go to the emergency room and show them that. And then they'll call the neurologist and the neurosurgeon, and they will do the appropriate tests, which would be injecting the nucleotide tracer, which is a radionucleotide tracer. It's basically, it puts you in a machine that can pick up on small amounts of radiation emitted from isotopes that are tagged to a tracer that's put into your spinal fluid, which they'll then see dripping out of your nose, is really the simple way of putting it. That's how you diagnose it. Next.
Next, this comes from Mick W. on YouTube, and they said that they've spoken to Richard twice and still haven't received a statement for the costs and what we will be doing. So they're kind of nervous that they're already falling through the cracks, and they are in need of 2 surgeries, and they're from Pennsylvania.
Oh wow. Okay. Well, thank you for sharing that. That's good to know. And what this viewer is saying is that they have talked to Richard here at Duke Spine, I assume twice, and still haven't gotten their cost. Here's what I would recommend you do right now. Call Richard. You can reach Richard at 321-775-1860, 1860. And I will tell him you're going to be calling him to find out what the costs are. So it's unusual that that would happen. I'm sorry for hearing that. We do have a lot of patients that want to come here and get fixed, as you can see. That said, there's no excuse for not getting back to people that want to get here and get fixed. So I expect Richard to give you your quote. I can't imagine why he wouldn't, unless, of course, we did a telemed and you needed additional tests before we finalized your plan. I don't know, but I can have Richard look into that. Obviously, I don't know your full name, and I don't want to know it right now. For anonymity and privacy, you should maintain that, but just give Richard a call, and if you're continuing to have a problem, you can give me a call, and I will take your call, and I will talk to you and figure out what's going on. But start with Richard, 321-775-1860, and if he doesn't give you your quote today, then I would be very surprised. And I think they asked for something, an invoice or something.
I believe so. I don't think it was in there.
Yeah, we don't do invoice. Just in case you're wondering, we won't give you a written invoice today because we haven't done your surgery. Everybody that gets the surgery done can get an invoice once the surgery's done. And the reason for that is we don't know 100% exactly what you need done. We know 99%. So you need to come here, get the surgery done, then we give you the invoice, because that's what we actually did. So maybe that will clear up things.
And the next question comes up from Billy Jones, once more on Facebook.
Did they have another question though?
Yes, that is coming up.
Oh.
Yes, that is coming up soon. Billy Jones's question is
nice.
Thank you. There's a little crack in it on the right side though, but it's all good. Billy,
these are Henry's.
Those are my glasses.
They just look really good.
Thank you. Walgreens. Billy asks, when are you going to train your brother over in Tampa area on your technique?
Billy, that's so good. That's Billy on Facebook?
Billy on Facebook, yeah.
Billy, I love it. You know, my best friend growing up was Billy. You ask a great question. My brother is a neurosurgeon, as you know. My brother has been trained in the traditional types of spine surgery, neurosurgery, like I was, but not as well trained. And he's aware of the endoscopic surgeries, but as I've said many times before, and I'll say it again, the endoscopic surgery does not pay well to the surgeon, okay? I made all my money doing fusions. It's the truth. I did fusions for, I still do them occasionally, but for 25 years. And fusions pay well. Much better than endoscopic surgery pays me. Why do I do endoscopic surgery? Because it's the right thing to do for the patients. It's not the right thing to do for me financially. And unfortunately, most spine surgeons will choose the most financially rewarding procedure for their patient rather than the best procedure for their patient. That's why we do this broadcast, so you guys can understand that fact. It is a fact, okay? My brother knows damn well how good my patients do. He knows damn well how good the surgery is. He's read the publications. But he and his partners are all neurosurgeons. They do spine surgery, lots of it. They do a lot of fusions, a lot of artificial discs, which pay well. Mostly fusions, which pay better. I'm sorry, folks. I'm sorry. I can't take responsibility for the actions of all the doctors, but I understand them, and I disagree with what they're doing. But what they're doing is a fact. It is far more invasive surgery. And honestly, here's the real problem. Why should endoscopic surgery pay far less than a fusion? That's the real problem. If you get the endoscopic surgery payment up to where it should be, you know, surgeons could make $5,000 or $10,000 a case for their professional work, then they would be doing the endoscopic surgery. Everybody would be doing it. The reality is they can't. They may get $500, may get $1,000. That pales in comparison to a fusion payment of $5,000 or $10,000 or higher. So that's the problem. Okay, I'm sorry, that's the problem. My brother knows what I do very well, and he knows that he could learn how to do it from me, but he chooses not to.
Next question comes from Samir on YouTube. And Samir asks, what is the reason for dizziness? I have issues with neck and scared of surgery. Family is not supportive for the surgery. What should I do? I also have an annular tear in the back, but it's not a herniated disc. How will you treat this annular tear? Once the extra disc is cleaned from the annulus, will the disc come back again in the future?
Samir, great questions. That's a lot there. So you asked me, you said you have dizziness. I don't know why you have dizziness, but when you have a herniated disc or spinal stenosis in the neck, it can pinch the spinal cord and cause imbalance, where you have trouble with your balance. It does not cause like your brain to be dizzy. Spinal problems do not cause like true dizziness. Dizziness for me is like you get up from sitting and you're like, whoa, your head is spinning. Your head is spinning. If that's what you have, it's not coming from your spine. You're asking me why you have it. If it's not coming from your spine, I have no idea why you have dizziness, but you need to see a good neurologist to figure that out. If your head is clear, but your balance is bad, that could be coming from your spine. Okay, so imbalance, spine, true dizziness, brain, blood pressure. Could be your blood pressure is too low. Could be you're dehydrated. It could be vasovagal. You know, there's a whole list. It could be Shy Drager. I mean, there's literally 100 things that can cause dizziness. But the spine doesn't cause dizziness, ever. Okay? Now, if I fix your annular tear in the back of your disc, then the annulus could heal. You will not get another herniation.
The next question comes from Mick, once more on YouTube, and they ask, how come no one has pain?
So Mick is asking, how come no one has pain? I think Mick is referring to the
Like after the surgery?
the patients that we treat after surgery. The reason, Mick, the reason the patients don't have pain is two reasons. Number one, the pain that they came with and the disc pain, we've gotten rid of with the laser. The laser cleans out the painful tissue in the back of the disc. It cleans it out. It's called the annular tear. All right? So that's the pain that they come with gone because we fixed it with the laser. The second reason they don't have pain, like everybody else has pain after spine surgery, the reason people have pain after surgery is because the surgeon cut them. And then when they went inside the cut, they pulled their tissues apart. And then they moved things and shoved them and cut them. There's a lot of cutting and hacking and retraction and damage that goes on below the incision that you don't see, but the surgeons do it during the surgery. That's why patients have so much pain after spine surgery, is all the damage done internally to your body. We don't have any internal damage with this surgery because it's endoscopic. Endoscopic surgery doesn't cause internal damage. The Duke laser disc repair doesn't cause internal damage. Therefore, there's no pain after the surgery. So the reason our patients are pain-free right after surgery, 95% of the time, is because number one, we didn't cause any internal damage with the surgery, so they don't have any pain from that. Number two, the pain they came with is gone. Now, we do have some patients, 5%, that have some inflammation pain that they've had for years. It takes time for that inflammation to go away. And that could take a few weeks, it could take a few months. But about 90% of our patients, 95, have zero pain, usually within a day or two after the surgery.
And that is it for questions.
We'll be back shortly. We have our next patient is having 5 discs fixed in the lower back, so go take a potty break, pop some fresh popcorn, pour yourself a Diet Coke, and get ready because we're doing a lumbar 5-level 2 incision. Patient is coming from California, and the one after him is coming from the Cook Islands over by Australia and New Zealand. And then the last patient is coming from Austin, Texas.